Good afternoon, everyone, and would like to welcome you all to the fifth of the series of webinar on practical bioethics. This is Atam from CHSR Nagaland. Last month, we learned about the Digital Privacy and Data Protection Act and its relevance in healthcare. And in this session, we are going to go through some of the case studies related to this act, especially related to mission hospital practice. And to take us through the case studies, we have two eminent resource persons from the last webinar, Dr. Joy Mammen, who is the professor of immunohematology and transfusion medicine, head of bioinformatics CMC Vellore, and Miss Anisha Koshy, AI and medical ethics specialist CMC Vellore. Yeah, thank you all for coming. And to moderate this discussion, we have Dr. Abhijit Sangma, Secretary Doctor Section CMAI. So without further delay, I would like to hand over the time to our resource persons.
Thank you very much, Mr. Abhijit and Antonia. We will start with a brief discussion to catch up from where we left off last month. So I'll request Ms. Anisha to start with a few introductory slides. We have created some case vignettes for us to discuss. We'll follow a patient through what may be an example of a typical patient registering in a smaller hospital and working our way through it. Nisha, over to you.
Thank you, sir. Thanks everyone for joining in for today's session. So this might be a little bit of a recap for those that were there in the last session. But based on the two topics that we will be covering today, one is consent and kind of operationalizing it and making sure that consent is valid. And the other thing that we want to talk about is institutional safeguards. So what are steps that we can take today to ensure that we start complying with the regulation? I just wanted to give a brief background of the law itself and talk a little bit about why we're doing this exercise in the first place. So the Digital Privacy and Data Protection Act came out in 2023, and specific rules around it came out in 2025. And slowly different institutions, and this is a sector agnostic law, so it does not just apply to healthcare, it applies to every single sector. And because we are in the healthcare ecosystem, we process a large amount of sensitive information. So healthcare information is sensitive information, sensitive to that individual, because in case that information were to leak, a certain amount of harm could come to that individual. So, the data that we hold is quite sensitive. And because we deal with sensitive information, we usually deal with large volumes of it, and we also deal with children's data. We are something that that is considered a data fiduciary, or a significant data fiduciary. And these obligations of the law therefore apply to us a little bit more stringently than it would maybe apply to another entity. So the law came out in 2023, and so far institutions have slowly been abiding by certain versions of the law. We have a planned phase for implementation. We're supposed to be fully compliant by May 2027. And the compliance journey starts from now onwards. Consent specifically is expected to be compliant by November 2026, so in a couple of months. So I want to talk a little bit about where we are currently and specifically a little bit more about consent. But before I do that, I just want to talk about the roles that we play in this whole story. So under the Digital Privacy and Data Protection Act, there are three different entities that play different characters. So the first person that we talk about is the patient or the user, or you and I, right? When we go to a clinic, we're called the data principal. We are the people who have the data, or we are the people whose data is personal to us, and we are sharing this information with another entity in order to, let's say, get some kind of service from them, right? So the data principal is the person whose data we're talking about, the individual, the person who has the data. And that data principal has rights. And those rights can be things like to be informed about what their data is being used for, how if they can correct their data, if they can erase their data, if they can file a complaint regarding their data. So the individual whose data we're talking about is considered the data principal. The hospital, in our case, or the entity that is collecting this data and then decides why and how to use this data, is called the data fiduciary. So as healthcare practitioners, we would consider ourselves data fiduciaries. And because we have high volumes of sensitive data, and we deal with children's data, and we deal with data that is largely sensitive, we consider ourselves significant data fiduciaries. So there's some additional compliance, but for the most part, we are the entities that hold the data and decide what this data can be used for. Right? So you have the data principal, which is the patient. We have the data fiduciary, which is the hospital, which collects the information. And then we have a vendor. So a vendor and a data processor can be anybody that the hospital, assigns to do certain tasks. So let's say we are using an EMR, right? And that EMR is not a inbuilt EMR, like the hospital didn't build it or the IT team didn't build it. It was built by, let's say, TCS or another company. That company, and we're leasing their software, okay, to use it. That company then becomes our data vendor, right? And we might have a whole host of vendors that we used in a hospital. So one can be your EMR vendor, one can be, let's say, your PACS and billing vendors. It can be some kind of compliance entities that you might have. So you might have a whole host of vendors that are linked to you. So those are called the data processors, right? So the data fiduciary picks who their data processors are. So these three roles are what matters the most to this story. And for today's conversation, we will be looking at this story from the perspective of a data fiduciary. So as a healthcare ecosystem manager or someone that is part of or a healthcare institution, what are our roles and responsibilities to ensure that the law abides practically to the data principle or the patient? Okay, so if we quickly just look at the bottom of the slide, you can see the compliance runway. The first compliance deadline that we have is the 2026, which is the middle, November 2026 is when we need the consent manager framework out, or we need a consent collection framework. We will talk a little bit more about what that entails in the next couple of slides. But the first touch point is 2026 November. And the next one, which is, the entirety of the law that we're supposed to be compliant by, is May 2027. So we're supposed to be compliant by all the different aspects of the law by May 2027. Now, that doesn't mean that we will do everything together. We just means that we will start chipping away at some portions of the act so we're able to set ourselves up for compliance in time. Right now, everyone knows that we won't be able to comply with everything, but there are practical steps that we can take, and we will talk about them towards the end of this presentation as well. Easy practical steps that we can take in order to make sure that we are complying with the process. So I'll hand it back to Sir to quickly to introduce this concept of this patient that we want to talk about, which is the case studies that we want to use, and I'll come back in a bit. Yeah.
Thank you, Anisha. We have used a typical example of an antenatal patient who comes in. This is her first pregnancy, and she's going to come in for the first visit. We are not at this point sure whether she will continue all the visits at this hospital or whether she's going to move on. There are certain traditions. The girl goes back to her mother's house for her delivery as well. But for the present, we assume that she will book here. And then once she's booked here, she's going to come back here regularly for routine care. And let us assume that there is an electronic medical record, and each time she comes in for visits, there is some additional data that we collect. As we all know, in the first trimester, we will take some clinical history. We do some blood tests, and in some situations, there is an ultrasound which is done. And there is a examination done for the patient, and the data is saved. So we have to now think of what are the different types of data that we will collect for this patient, which of it will be electronic, which of it will be on paper, and how we are going to make sure that we are going to be compliant in the various aspects that Anisha has been speaking about so far. Next slide, please. So there are 4 aspects that Anisha has listed out for our clarity. One is about the visit itself, getting an appointment and coming. And there are certain assumptions in this. Now, this might not always be typical for all the persons who are in this meeting. Maybe there are variations as to how patients book an appointment, come to the hospital, and see a doctor over there. But generically, we will talk about how we will take consent at the time of booking or taking an appointment at the clinic. What we need to do at the clinic itself, what are the documentation that we will create, and if it's an electronic, if the data that we are collecting and storing is in electronic format, what needs to be done for that? And then what are the follow-up actions which we are responsible for when patient wants information or access to their electronic data. Over to you, Anisha. You can go forward.
Thank you, sir. So, yes, so these are the 4 broad areas that we will be talking about today. And I'll jump straight into the first story that we have. So the first one is the booking the visit itself. So under the letter of the law, we are supposed to collect something which is called consent. Consent is the basis for which the patient allows us to use their own data for different things, right? And we as healthcare institutions might want to collect their data for a variety of reasons. It can start with things like actually given care, delivering actual forms of care, or it can be, let's say, for example, doing research. It can be for sometimes it can be for insurance verification. It can be for billing. It can be for a whole host of reasons. It can also be very simple reasons like making sure that they are part of some kind of government scheme, etc. So there might be a whole host of reasons for which why we might want to collect patient information. Now, the best practice to follow is to give the patient something of a terms and conditions sheet, right? At the first point of visit, for the first point of interaction, we tell them that, you know what, these are your terms and conditions. Right. So let's say Meera, when she comes to our clinic for the first time, if this is the first time she's coming to our clinic, ideally, we should tell her, these are the types of information that we will collect on you. It can be things like scan information, so imaging, it can be blood work, so pathology reports, it can be, it can be a whole host of things that we will collect. We follow an electronic medical record system, so we will be putting all of that information onto our system. These are the steps that you can take in case you want to see the information that's available on our system. Let's say, for example, Meera, the first time she visited, by accident, she said her age wrong, right? But let's say at some point or other, she realizes by looking at her records that she accidentally gave her age wrong. So she can come back in and change that age at some point and say, I want to verify it. And you'll have a system where you'll actually look at her Aadhaar card or something like that and say, okay, this is what her actual age. Go back in and change. So you have the right to correct her information. And she also has the right to ask a question. How long will you keep my information? Who all can see my information? What all can my information be used for? So these are all valid questions under the rights that Meera has. And we should ensure that there is a format by which she can, she can communicate these challenges that she may have. So consent, as I said, that before we collect consent, which is her nod to saying, yes, you can use my information for, these specific reasons, we have to give her something which is almost like a terms and conditions sheet, which is called the notice, where we say, these are the specific reasons for which your data will be collected. This is how it will be collected and stored. These are the number of people that will have access to it. This is all we will do with your data. And then once we have, used your data for whatever reason that we need it to, unless it's a medical legal case or something like that, we won't store it. We will delete it as per this policy. Right? So this is a clarification that we provide at the beginning. So based on the information that she has read, she can then say, okay, you go ahead and use my data. Now, consent. Now, it can't be a situation where we give her this whole host of things and then she just signs at the end. That is not valid consent. Again, the letter of the law is very specific. The consent has to be valid. For consent to be valid, there are some characteristics that the consent collection must have. The first one is free. So when she is giving consent, she shouldn't be under some kind of duress. You can't say, unless you give me consent to use your data, you won't get care. Just because she says no to giving her consent for, let's say, research information, like using her data for research, we can't withhold care. So she can't be under duress when she's giving consent. Consent has to be free. She has to freely give that consent. Another thing is specificity. So we can't say your data is going to be used for clinical care, routine checkups, for, let's say some kind of interportability, but it's also going to be used for research. It's also going to be used for advertising. We can't give the whole information in one long document and make her sign at the end. She must have the choice to pick between what she's okay with and what she's not okay with. The standard example is cookies on, when we visit certain websites. So, you have accept all cookies, which is fine, or you accept the cookies that you're comfortable with, and then you reject the ones that you're not comfortable with. So that is specific consent, or that is the term that everyone's been talking about, which is itemized consent, is exactly that. So consent that is split into specific sections, and then the user then gets to choose between what is allowed and what is not allowed. The third and most important is informed consent, which means that let's say she's a young mother who's just come in. We don't know her education background. We don't know the languages that she speaks. We have to ensure that she fully understands what she's consenting to. And that's actually it's a fairly simple exercise. We just have to make the consent available in a language that she is comfortable communicating in. Either she's able to read it and then understand it, or someone is, visually explaining it to her, verbally explaining it to her, or there's a video of some kind that's explaining it to her. She simply has to understand what she's signing off on, right? So informed consent is highly important. It also has to be plain language. It can't be something that, only lawyers or very technical folks can understand. It has to be very simple that any user can make sense of it. The fourth is unambiguous. So consent, again, has to be an affirmative action. So I'm sure that everyone that's been on the website, like been on the internet for the past couple of years, will have noticed a stark change in how we give access to cookies. Before, cookies used to come pre-ticked, and it was just a go ahead, right? They weren't really asking us for our choice. They were just literally informing us that there are web crawlers on our system. But now it's not pre-ticked. It asks us to tick. So, the affirmative action of the individual choosing for something to happen is when consent is valid. So it has to be ambiguous. It can't come pre-ticked. She has to tick and then say, okay, I agree with this, this, and this. It has to be unconditional. Unconditional meaning, it's similar to free. It can't be tied to something else. Her consent can't be linked to, let's say, we saying that, okay, your care will be subsidized. Or if you sign off on this research project, we will give you this and that. So it has to be unconditional. It can't be tied to something else that she thinks she's going to benefit from, and hence she's giving consent, right? Because data is money in a way. So she has to be okay with giving us the data so that we have access to it. And the last is revocable. So consent, let's say she gives you consent today, and then she goes away, delivers the baby somewhere else, and 2 years later realizes that, she actually visited this hospital back in the day and she did like a routine set of tests. Now she doesn't want that hospital. This, again, the caveat is that this is not a medical legal case. She assumes that, I don't want you to have my data anymore. She should have the ability to come back to us and say, all the electronic medical records that you have on me, please delete it. And then we should do our best to ensure that that data is deleted. Right? So consent also has to be revocable. At any point, she can come back and say, I don't want my data to be with you. I want to revoke it. Now, as hospitals, we have the right to say that, okay, if you revoke your consent, your records will no longer be with us, which means that in the future, if you need some kind of care, we might not have access to it. That's absolutely fair to say. But again, if she then chooses that, no, I still don't want you to have access to my data, we should have a system to delete it. So these are this is just an example of what itemized consent should look like. So, what is absolutely necessary for giving her care, right? Antenatal care and routine screening is absolutely necessary. Essential clinical sharing. So that's labs or referrals or pathology reports or, any kind of diagnostic or pharmaceutical documentation, etc. Those are absolutely necessary for giving her care. So we tell her these are absolutely necessary for giving you care. And then there are optional things that, are not necessary or directly related to her care. So that can be things like use of teaching or case presentations if you're a teaching hospital. Or what it can be if, for example, you've taken a picture of something and you want to use it later in your social media or you want to use it for marketing. None of that is necessary to her care. She has the ability to choose what she's okay with and what she's not okay with, right? So these are just some quick checklists that you can follow. One is layered notice. So 1-page summary, and then they can pick what, makes sense to them and what they don't want, can be left empty. A short verbal check right at the end. This is the part where you need to make a choice. Just a quick explanation of everything is a short documentation. And you need to record this only once. So even for the law, you just need to do this at one point and you can decide what that touch point is. Ideally, the best touch point is right at the beginning. So when the patient is coming in for the first time, if you get that at that point, unless she comes back to you and revokes it, you can keep that data and you can decide to do what you want with that data as long as she's allowed for it. Right? So we don't have to keep going back and doing this exercise again and again. Right? So that's the first part of the story, which is the patient just coming into the clinical system. The next is while she's there. So while she's there, a whole host of people usually have access to, a patient's records. And that is just a standard experience of what hospitals are like, right? So if you just walk to any of these wards, you'll realize that usually, you have your EMR on, you can see a lot of patient information that is just visible on computers all the time, right? So, and this is not necessarily always gate kept. It's not necessarily access controlled. Anyone who's walking by with a phone, any nurse or allied health professional or anyone, an aid worker, anyone could take a picture of a screen and then have that information to themselves. It is highly important for us in our story to realize who has access to what. Right. So in Meera's case also, we should ensure that only the people that are absolutely necessary to give her care have access to it. That's why there are systems of referrals. right? That's why there's very specific individuals that are called in to see her clinical records. So protecting that record is absolutely necessary. So even with things like if you have general computers in wards, etc., that is facing a whole host of people, it shouldn't be the case. Or having some kind of login and access control or password control where not everyone can log in, or not like a common login. It's individualized and only certain types of people can log in and look at information. And this becomes even more complicated, let's say, for things like mental health records, right? Because the data protection law is the baseline law. There are other important laws that sit on top of it. So or let's say HIV records, for example. So there's other levels of controls that you have on top of it. But making sure that the people in your hospital ecosystem, which is in the clinical ecosystem, all have some kind of access control when they are looking at another patient's information. That's absolutely important. So just looking at the bottom of this, you'll realize I've addressed two, which is individual accountability and least privilege. But I want to talk about the last one, which is trained conscientiousness, which is the fact that, you have to have training exercises in order to sensitize the folks in the hospital for them to feel like, okay, this is not something that should be allowed. Only certain people should have access to certain information. I think culturally in India, we feel that, we can look at anyone's records because they've come to us and they're in our vicinity. So now we have access to their information. That's absolutely not the case, right? Again, this is an exercise in due diligence. This is an exercise in best practice where we ensure that everyone in the hospital is somehow sensitized to the fact that they can't, unless they have access to look at that patient's information, they should not be allowed to look at that patient's information. And looking at that patient's information is a breach of trust, right? Anyone who looks at information that is not, theirs to look at, they should feel like that this is a breach of trust and some entity is watching them. So it can be something like, if there is a login from a certain computer with a certain ID that's not supposed to access it, there should be some kind of accountability measure that the institution has where, that they're keeping logs or records, but they're like, why did you access this information from this computer? That kind of oversight is vitally important because, again, it's a question of due diligence and best practice. Because in case there is a breach down the line, we can preemptively say, no, that we did our best. We ensured that our staff was trained. We ensured that we did audits. We ensured that our systems were locked, right? So this isn't an error simply on our part. That's vitally important to also, have that kind of legal callous around due diligence when it comes to data protection. Again, so what are the safeguards that you can put in place immediately? First, of course, it is digital safeguards. So it's things like role-based access. So unless you have a certain role, you can't access it. Individual logins for each staff member. So you can log into systems only with your individual login. And also it's impossible for another person to steal your login and then, log in because they're logged in somewhere else. Another is sense, like physically you can protect it, angle screens away from public view. That's vitally important. If there's any kind of case sheets, etc., that is digitized, don't make it, publicly accessible to a whole host of people. And especially in situations where one person is doing multiple roles, if the nurse is also the person that's dispensing with the drugs, they should have some kind of system where it's not the same person doing everything. And this I know is in a slight problem, especially in mission hospital kind of work where we can't hire that many people, but still important that we have some kind of sensitization around it, making them feel like, what they're doing is important. The last is, of course, training for people, ensuring that training is, that there's some kind of privacy training that is done from the beginning. Domain 3, I would say, is the record. So this is record keeping. Now that the data is collected from the patient, so let's say Meera's story, Meera's information is collected. Who has access to it? For how long do we keep access to it? And how do we protect it? Right? So that's the next story. So which is what we call the data lifecycle. So how do you collect the data? How do you store the data? How do you retain the data? And then if you want to keep retaining the data, how do you de-identify it? And how do you finally securely dispense of it or delete it? So when you say collect the data, you collect the bare minimum amount of data that is necessary to give a particular action. You don't collect data just in case and keep it. Right? What is the bare minimum that we need? The principle is called data minimization. You collect the least that we need to dispense off with care. Store, make sure that the data is stored safely. It's encrypted in some kind of digital locker, or it's kept in a safe database somewhere. Retained. For how long do we have to retain this information? If it's not a medical legal case, how long do we keep it? And under what conditions do we keep it? In case we want to share this information with someone else, how can we securely share it? So, for example, in a hospital ecosystem, there's usually some kind of encrypted system to share it, or there is some kind of, tool like, let's say, Microsoft Teams or something like that, which is allowed and verified by the institution in order for information to be shared within. And, that we stay away from sharing information on platforms like WhatsApp or Instagram or things like, which is absolutely a no-go. And then finally, how do we delete this information once the data is finished its life cycle and we don't need it anymore, to ensure that the whatever drives they kept on are wiped and the database is clean and there's no any sort of ghost in the system. All the data is wiped clean. So that entire setting up of that life cycle is also very important. The last is around, a reasonable request around her own data. Now, let's say this was the story about Meera, where we said that, Meera has decided to then move on later and then comes back at some point and decides to ask this question. I have some questions around my data, right? I want to see how long it was kept, or, I want to see. It can be any question around their data. It can be like, oh, I want my data deleted, or I want my data to be transferred to a different hospital, something, right? Who can Meera talk to, right? Is there any individual in your hospital who's assigned to do this? Now, by the letter of the law, we should have someone assigned to do this. And that individual is often called the data protection officer. So it can be anyone. It can be someone who is from within the hospital, who's elevated to this position, or someone who's hired from outside. But this is their primary job. They're called the data protection officer. Their entire job is to ensure that the data protection best practices in the hospital are carried out the way that it's supposed to. Now, because we're all significant data fiduciaries, this is an absolute obligation that we have, which is to hire someone to do this. Now, this individual is not a traditional IT person. It's their job is not to be a typical IT, like, your head of IT would be. This is more of an administrator role. They have is sort of like a mixed characteristic between an IT professional and someone who's more of a compliance legal officer. And, it's their job to do all of these things that I told you before, which is, in case there's a grievance redressal, in case there's a grievance that's come out from a patient, they redress it. In case of a breach, they are the person that is, charged with talking to the data protection board and reporting on the breach and following up with them. They're kind of like the ambassador that your hospital sends to the data protection board. It's their job to do training exercises and sensitization. It's their job to ensure that all of the privacy best practices that are getting put in place are actually carried out. So having this individual is vitally important, because let's say in our Meera story, if she were to come and ask our clinician and say, hey, listen, what happened to my data? A clinician will never be able to answer what actually happened to their data, simply because they don't know what did. So they should be able to point them at the right individual. And in our case, it's the data protection officer. They should be able to send Meera along to their office and then have them coordinate directly on any data related questions that may come up. So I'm going to quickly talk a little bit about the checklist, which is the things that we were talking about. So these are some initial do's and don'ts that we can think about. The first is collect the minimum, right? What is the minimum amount of data that you need on any individual in order to give them care, right? Not to do, additional things like, let's say, for example, research. You will obviously collect data for research, but ensure that, the essential checklist is what do we need to do as a hospital to give them care. And then any additional information can be put under that as optional, and they can take if they wanted to. And explain everything before you start recording data. This is again why we said that the first good touch point for when you should give this documentation, which is the notice and consent, is when the patient is just coming to the clinic. The next is itemized consent. So separate necessary from optional. So give them a necessary list of things that they need to comply, they need to check, and then give them an optional list so they can see, what they can check and what they can't. Lock it and log it, right? Lock it and log it is very simple. Lock it, physically lock your systems. Give access to only the right people who should have access to it. Log it. Make sure that anyone who has a digital footprint, anyone who interacts with one of your systems is logged somewhere. So in case of a breach, in case of a hack, you know where to go find the right person. De-identify for teaching and research. So in case you're going to use this data that you collect on the patient in order to teach or in order to do research, make sure that it's de-identified. Make sure that the patient's information is masked. Make sure that the patient's information is anonymized so that patient data is not leaking into other parts of the exercises that the hospital has carried out. The last one is name an accountable lead. For this, what we mean is have a DPO in charge. Have someone even by title named a DPO and kept on your roster. publish their contact information, wherever, if you have a website or a brochure or something like that, publish their information. So if anyone needs to contact them in case of anything, they know where to go. And last is, in case of a breach, is supposed to report it in 72 hours, but that is something that your data protection officer would be in charge of doing. So they will do that. The definite don'ts for our system would be, don't rely on a blanket signature for everything. Just because you explained everything to the patient, don't somehow ensure that the patient is just going to sign a blanket signature. Itemized consent is vitally important. Don't share patient information on unauthorized channels like WhatsApp or Instagram. Do not discuss sensitive results with others where they can overhear. This is also important. Don't leave systems open. Don't leave computers open. Don't have a whole host of people discussing patient information loudly in the corridor. Open a record for anyone not in your care. So do not open a record for anyone that is not directly in your care. Now, what that means is all these patients are your legal responsibilities. When they come into your hospital and start giving you data, they are your legal responsibility. Don't take on any additional liability for no reason, right? Keep records indefinitely without a rule. If you have records that's collected, ensure that you have a deletion mechanism. If you don't need that data anymore, make sure that if you really need it, de-identify it and keep it somewhere else. But if you don't need it, go ahead and just delete that data. The data is not necessary for routine care anyway. Leave screens unlocked or files on the counter. Make sure that any of these screens are not widely accessible to the general public or to those that do not have role-based access to that information. So the last thing that I want to talk about before I come back here are 6 practical moves that you can use. So the first one is name your lead. Appoint a compliance person, a compliance lead or a DPO, and they then become the point of contact for patient questions. Redesign the form. If you're collecting consent, please ensure that the consent is a one-page form, that the notice is a one-page form, and it is itemized based on the principles that we spoke about earlier. So just redesign that form and make sure that they have a system to which they can consent. Close the access gap. So ensure that there's no shared logins or a common login. Everyone has an individual login that's based on their roles. Last, train briefly, do training exercises as often as you can. Sensitize the crowd in your hospital and make them feel like the data that they're collecting on the patient is not some stranger's information. This is what will happen to them as well. They're also patients in some sense. So make them feel a sense of responsibility towards the data. Last is write a retention rule. Have some kind of system or a data governance mechanism. So a lot of hospitals don't have a data governance mechanism. Have some kind of mechanism where you say that, this is what we will do when the data is collected. This is how we will store it. These are the encryption standards we're going to use. Once they use that, this is how we're going to delete or this is all we're going to retain the data for. So have some kind of data governance principles. And last is map your data. Know where your data lives. Now, we already are collecting large sorts of data, right? So this is not an exercise that we started today or yesterday. Know where your data lakes are. Know what the most amount of data in your hospital is, the most amount of data in your hospital is collected from, who is in charge of it, who is watching over it, what are kind of the de-identification or anonymization systems, if you have any, what those are. So do this initial exercise. And these are kind of like 6 practical moves that we can start off immediately to start with the compliance process. I know this was a fair bit of information and I kind of wanted to wrap this up as quickly as possible, only because I know we have limited time and we may have questions. So I'll hand it back over to Dr. Joy to take it forward.
Thank you, Anisha, for taking us through what are points at which we can start thinking about our compliance. So the important thing, as we mentioned, is making sure that we get consent appropriately, and it's not like a broad consent, but we try to itemize our consent. The second is to make sure that we have accountability and we have somebody responsible, and who accesses the data hereafter, especially if it's electronic, needs to have an audit trail. And the last is about making sure that we maintain a data lifecycle plan, get the data that you need for the patient care, and then secure it appropriately. Make sure that where you are going to use it for research, you have appropriate IRB and ethical permissions for it, after which you can de-identify it and move it out from your clinical store. And if you're not using it for clinical data, for purposes clinical, you have to delete the data as per the regulations which are prevailing. So I will stop over there. Dr. Abhijit, we are open for questions. We have about 15 minutes, I think, for questions, or 20 minutes, I think.
Thank you so much, Dr. Joy and Anisha, for taking us through. Dr. Joy, in terms of, in a high demand, in a high volume hospital, the OPD requirement for the itemized consent can, sometimes feel like a bottleneck, too many things to do. Is there a way to integrate this into the registration process without significantly increasing the wait time for patient?
Yeah, I think that would be the wise thing to do. We move these things along the care pathway. So when somebody is registering with us, I think currently we might have a short consent to say that you are now consenting for us to take your data down. And there is usually a long privacy and terms and conditions page, which are legal, people might have drafted and given us. So now I think the opportunity is there to itemize consent and display it to them so that they understand it. And I think there's also an opportunity now to translate it and make it available in languages that people can locally understand. At least up to the consent step, if you can make documents available in local languages, then it might be easier for people.
Thank you. And in many of our mission hospitals, we see, shortage of staff is one major issue, and we see that we have a single staff member, like a nurse or a technician, often performing multiple roles. They help in registration. They also provide clinical care, also dispensing medicines. So how can we practically implement this role-based access or individual logins when staff they need to jump between different system functions and quickly to manage patient flow?
Yeah. Now, this is something that we thought of also during our discussions when we were writing up the vignettes. It is a challenge, especially in smaller hospitals where the same person who registers the patients might be the one who will go to might be doubling up at some time of the day for to help with the pharmacy or to help with the lab registration or sample collection, etc. Now, roles can be assigned to different individuals. What we were talking about is role-based access. So in the system, you might define that an individual can have a role called the computer technician or the clerk to collect or register patients and also do blood collection. So there might be different roles that you will assign to the same person. So long as the roles are assigned, then we know that it is appropriate for that person to log in appropriately and do it. The challenge will come when people want to just log in once and do all their tasks using the same login. And sometimes we know that in busy places, people tend to log in and leave the computer accessible to everybody who turns up at the counter and sometimes forgets to log out when they leave the shift also. We've had problems in the past and it is challenging. And especially if you have a moving population or a young population who are not oriented fully to this. One thing is repeated training. The other thing is that in our lab, for instance, at one point we had this as a major problem, but the workaround was that if there is a problem with the result and there is a official administrative action to be taken, the person who's logged in will be the person who will be answerable for that. Then there are technological solutions which sometimes can become very challenging. But in our system, I think 15 minutes later it logs you out, and there are certain specific areas where there are longer permission times. But by and large, at the end of 10 to 15 minutes, you're logged out of the screen because people share offices and move around. I'll stop over there. If somebody from the audience has some suggestions, we're happy to listen to that also.
So you're able to mute your mic now. Plus, you can type in your questions in the chat.
Yeah, I must also put out a disclaimer that this is not the official position of CMC Vellore. We are in the process of evolving our own positions also. We have come to this understanding based on our reading of the Act and literature and our experiences with different groups in
Yeah, there is one question in the chat. It says, what do you mean by data patient history is imported for future treatment? If we're able to delete data, how do we know what happened about Abha and Ayushman? WhatsApp is rampant with the hospital within teams.
Sorry.
Yeah, and just along with the WhatsApp, I think because we know that WhatsApp has been a tool which is, it's a dilemma which has been always used for reliable, communication between, different teams. And since the Act views this as a no-go, in a sense, using sharing, so what are the low-cost or low-bandwidth encrypted systems that a small hospital can adopt without hindering the urgent care? I mean, without using WhatsApp to share information. Just to add along with since the WhatsApp came in.
Yeah, let's start at the top first. One is when you say what do you mean by data patient history, of course, yes, is important. So the consideration is that you will have a written policy saying this is how long we will retain patient data for. And usually it is from the last visit. So when we used to maintain paper records, we used to have a policy that if a chart is not active for 5-year period, I think, if I'm not mistaken, we would shred and discard the charts. We simply did not have space to continue accumulating charts. So this would follow the digital version of that. So if you do not have patient activity, then there is no reason why you should store the data for clinical purposes. That would be my simple answer to it. If anybody else has another position, I'm happy to listen to it. Anisha, you have any thoughts on that?
No, sir, I don't have thoughts on the WhatsApp part of it, but I do have an answer to the first part of his question. So what did they mean by, if we delete patient information, how do you continue to give them care later on? So when they ask for, let's say, data deletion, it's absolutely within the institution rights to say that in case your data is deleted today, when you come back here for future care, we might not have access to it. And especially in the age where everyone is moving away from paper records and paper charts into digital health records, it's absolutely fair for you to make that claim and say that in case you come back, your history will have to be collected again. Your care might be delayed because of because of this exercise, and we also might not have longitudinal data on you, so we might not have all of this information, and you have to be the reliable narrator here. You have to give us all this information again, and it's all entrusted on you. That's an absolutely fair thing to make them aware of before we allow them to delete their data. So it can be like it's like positive friction. So you're saying that, these are all the conditions under which please understand it before you go ahead and delete your data. If they still want to go ahead and delete their data, there is nothing that we can do about it. We just have to delete it. And then if they want to come back for care, we have to recollect it. But we absolutely are within our rights to do this exercise beforehand. And unless it's a medical legal case or you're retaining that data for some kind of government subsidy or government intervention or some kind of scheme, the patient is well within their rights to ask for data deletion. It's completely fair.
The question about what about Abba and Ayushman? Abba offers a way to identify patients. And now I think there is increasing requirement for all healthcare organizations to include ABBA within their HIS, and DPDP is now certifying or badging hospital information systems. And one of the criteria for getting your certification from ABDM is to say that ABDM compliant is the fact that you can either create or store the ABBA ID number. The use of the ABBA ID number is hopefully that it will remain unique, and when patients move from one hospital to the other, that will remain as a unique identifier. And ultimately, it is envisaged to be the key with which data will be shared when all things are interoperable, whenever that happens.
We have Dr. Ashish here from Father Hospital. Do you have any questions for our resource person?
I have a lot of questions. So the ABHA and AVDM, they want your data. They want the patient's data so that it is available to the next wherever.
Sorry.
It goes against what you're saying that they want to make sure that data is available down the line, longitudinal data. Is the patient's data going to be deleted from the ABA database?
At this point, I'm not aware that we are submitting patients' data other than identification to ABA. Is there anything more than that now?
For every other transaction, it seems to be. For example, registration is one. They want your OPD, they want the lab results, and treatment if possible. Discharge surveys is what they want also. I mean, those are the steps that they want us to do. Right? Whether it's completely, we have just started ABA registrations last month, so that's what we were told. All the data has to.
You're supposed to upload patient data.
Yes.
To which site?
We also don't know if it is linked to the ABA part in the app, the hospital, and it gets loaded to this.
Sorry, I'm not aware of.
I attended a seminar with the Ayushman people, and there they came out strongly that they will want all the registrations to be done, and anything subsequent to the registration of the patient, registration, meaning history and examination, lab tests, and whatever else that follows, they want the data. I don't know whether we are uploading. I believe our software is what is it called? It's linked to the ABA already, so weeks ago. So I don't know how much.
We have been incorporating ABA ID for the last 2 years or something since NMC made it mandatory.
Okay.
But to the best of my knowledge, we are not uploading data anywhere. Okay. All our data is still remaining local and stored local.
Yeah, ABA's framework is a federated system, as far as we know, where the data continues to remain with the individual institutions, and only maybe some kind of metadata or specific IDs and registry numbers and things like that are going back. There's no central server to also keep all of this information. Like realistically also, the amount of money that they would need to potentially put onto all of this patient information from every single hospital is absolutely enormous. So it's a federated system. So ABA information, or the system that's going, is a fractal of metadata that's going back to the system, but the patient information is still continuing to be held locally within that hospital ecosystem itself. So that's their official position. Now, I don't know if they've started asking, hospitals to start sharing their data centrally, but their official position is that it's been held locally. Yeah.
But think about WhatsApp. Is it absolutely banned for clinical use? I mean, people use it within their departments. And morning I get intake output charts and things about the patient.
See, the problem, the liability will be on the hospital when something goes wrong. That's the boundary that you should look at. So CMC's official position is you should not be using WhatsApp for patient care. Now, do people use it? I'm sure they do, but that's not the official position. So if something happens, you know how easy it is to mistakenly forward a message to somebody, add somebody into a group by mistake, and share information within a group. That is where the challenge comes. And I think about a year ago, we were all privy to what happened in the US, where the defense secretary himself included a journalist, the editor of a journal, into their top secret WhatsApp group, and then everything came out. So things can happen. It also makes it much more easier to share. Once it's on a WhatsApp platform, it's so much easier to share and for mistakes to be made. We all have made mistakes. We posted things into wrong groups, deleted, apologized, been embarrassed at the most now. But I think if it goes into the wrong hands, then potentially things can go wrong. And we should be wise to it. I can't think of a low-cost encrypted software which is easily available, Abhijit. Some people have been telling, why don't I try Signal? But although Signal is owned by a foundation, I think all the operational aspects still remain the same. You form groups, anybody in the group can receive it. All the other operational things remain the same. So you do it at your own risk. And it is a challenge. So I think in some places they have versions of like Teams or one of those kind of programs which you can access on your mobile device also. but they come with a certain cost. So it's not easy to change. And also, even if you have Teams and chat and all that, people just don't want to move out of WhatsApp. There is an inherent ease of use and convenience in having WhatsApp. But we take it with the risks, Dr. Ashish. So we should be prepared for that also.
I think the same challenge we're also facing in CMAI. We have Office 365, Microsoft 365, and we have Teams, but communication happens through WhatsApp for convenience rather than using Teams.
Yeah.
One thing is, like even now, I'm sure that many of our hospitals will still be using paper. I mean, they're transitioning between paper and digital records. So how does the DPO's responsibility and the patient's right to the erasure extend to the physical paper files that are later scanned into the system? Or does the Act strictly govern the data once it becomes digital?
Yeah, so the Act only applies to digital information. So let's say a patient's paper charts get stolen by someone and taken away or something. It's a petty crime. It doesn't come under data protection at all. I mean, one could very well argue it's data protection, but it doesn't come under digital privacy and data protection. So unless the data is digitized, so you said paper charts, unless if someone is taking a soft copy of it and then uploading a PDF, then absolutely it is any kind of breach is fair game, is well within the purview of the law. But if it's, if it's, as long as it's not digitized and it's paper, then the law, at least the law does not apply. That is what it is. Yeah. It's not to deter folks from, digitizing their hospitals. Please digitize. But, it's not at least for the sentence of the law will not apply if it's paper records.
Can I say something?
Sorry.
Yes, Dr. Ashish. Yeah.
Sorry, this is from our IT guy just walked in, and this is his phone with the Abha app on it. The Abha app from the government. And
we can't see it.
I know you won't be able to see
Okay.
it. I don't think, but it is his data. But it has everything. It has his OP consultation, which has his chief complaints, the prescription, diagnostic reports, all on Abha. It's come from our hospital, gone on to.
Okay.
It's from which hospital? Sorry.
From our place.
Okay. And what is the software you use, Dr. Ashish?
Grapes.
Okay.
This Abha came into last week only. 2 3 weeks. 2 months. Sorry.
Okay.
There are other digital, I mean, apps also which are there, which is using the Abha API to, generate OPD registrations and all. But I don't think you can see the other records in them. They're just connecting you to the hospital EHR and getting the appointments done, the registrations done. But again, you'll have to go to the hospital and get the prescription pad and everything there in physically.
For the hospitals which are ahead of us on the curve, there are also, I think, hospitals which use transcription software, voice recognition software, AI which summarizes your application, which runs off a cloud application. In all those situations, again, you should now start asking the questions: where is your application hosted? Is the voice being recorded? How is it being transcribed? Where is the voice recording remaining in the process of transcription, after transcription? Who has access to those? Does your vendor delete those files or saves those files after they are transcribed? All those things, especially now, ambient listening is becoming very popular, ambient scribing. So there are apps which are very easily available. I think you should be wise when you start adopting technologies like that. And there is also the question of consent from patient to make sure that they are aware that there is a listening device in the room that is recording their conversations. I know the reverse might be happening. Currently, we teach our trainees that just assume patients are recording your conversations. But now if we are offering that service, then we should include that in the consent, or we should display signage appropriately to say that we are using technologies which will record your voice and store it for office purposes.
I think similar notices to you are under CCTV surveillance.
Yes,
Is
yes.
there any other questions for our resource person? It's we just have in the last few minutes before we end. So, if there are any other comments or questions from our participants here, guys, just want to thank Dr. Joy and Anisha for taking us through this very practical, case study. And as we conclude this session, a few key points that stand out, and I hope every participants takes it back to their institution. I think what we have learned is that digital act is not just an IT issue; it's a clinical and administrative responsibility. Whether it is how we handle a WhatsApp message or how we explain consent in a busy OPD, it requires a shift of our culture, institutional culture, and I think for many of us, we learned that the punishment is, the penalty is 250 crores. And I don't think any of our hospital will be able to pay that. So the due diligence is our best defense, starting with, staff training, rule-based access, and clear privacy notices. That are essential first steps in ensuring that we are acting in the best interest of our patient. And the heart of bioethics is the trust between patient and the healer. So in this digital era, protecting the patient's data is simply a modern extension of, do no harm principle. We must ensure that our systems become more high-tech as care remains high-touch and high-trust. So I want to thank our resource person for their incredible clarity and answering many of our questions that have come from the frontline workers. And thank you.
Thank you. Thank you, Dr.
Thank you so much. And next session will be next month, in the second week of the second Thursday. So please do join. We'll keep you updated. If you have not registered, please register using the link that has been shared earlier. So it will help us to send messages to you, emails to you with the updates. So thank you so much for joining. Thank you, Atem, for being the host today. Let's see you all next month.
Yeah, thank
Have a
you.
blessed evening. Bye-bye.
Bye-bye.